such damage, like chemicals, radiant energy, and microbial agents. Do you know any environmental factor which is carcinogen? UV, yes, one of them. UV ray is very important, especially in sun exposed area in the tumors of skin. Yes.
I said UVB is more harm.
UVB.
Yes, UVA is okay.
Okay.
And UVC doesn't.
Okay. The other environmental factors.
Ionizing radiations. Ionizing radiations.
Yes, radiation. Other.
Biological factors like bacteria, viruses,
Bacteria.
parasites.
Do you know any bacteria?
H.
pylori, yes. H. pylori is very important both in the stomach, adenocarcinoma, and also in the lymphoma of the stomach. Yes, virus. Do you know any virus? HIV, yes. EBV, yes.
Hepatitis B and
C, yes. HPLV1 maybe, okay. The other HPV. You know HPV. Yes, yes. The other thing.
Parasites. Like
Oh yes, parasites. Yes. Yes. Okay. Other more common things.
Cigarette smoking.
Yes, exactly.
In the
Cigarette,
chemicals,
tobacco.
asbestos and alkylating agents like dyes.
Exactly, very good. Some drugs, yeah.
Benzene.
Yes, exactly. Some chemicals. As you said, for example, some material in cigarette and tobacco, and also in alcohol, and also some food preservative, yes, some food preservative, and also some fungal element, for example, they are carcinogen. Okay, now about chemical. You know, about 200 years ago, one surgeon found that scrotal skin cancer is very common in chimney sweeps because of chronic exposure to the soot. And after that, the physicians and scientists found that some chemicals are very important and are related to some types of malignancy. Chemical carcinogens are some highly reactive electrophile groups that can directly damage DNA and leading to some mutations, and after mutations we have some types of cancers. As you said, we have two types of chemicals. Some of them are direct acting and some of them are indirect. What's the difference between direct acting chemicals and indirect acting?
Direct acting, they're already in their active form. They don't need to be metabolized or converted.
Yes.
But indirect, no, they're in a non-active form and they need to be changed and then they become active. And
Yes, they need to some metabolic conversion. But okay, direct acting require no metabolic conversion to become carcinogenic. We have some good example for direct acting. You know, these direct acting are some big carcinogens, but they are very important because some of them used in some drugs. Some of them are used in some chemotherapy drugs. For example, alkylating agent used in the regimen which we use to cure some types of cancer. For example, for curing some types of lymphoma, like Hodgkin lymphoma, we use these drugs. And after some years, we have a second form of cancers in these patients because of this drug, and most of them are leukemia. This situation is more tragic when the initial use is because of non-neoplastic syndrome. Sometimes because of some rheumatologic disease like rheumatoid arthritis or Wegener granulomatosis. Sometimes we use from this drug, and after some years we see this patient by a type of, for example, leukemia and a type of malignancy. But indirect acting, as you said, require metabolic conversion to be carcinogens. The most potent indirect acting chemicals are polycyclic hydrocarbons present in fossil fuels. Benzopyrene in smoking of tobacco can cause lung cancer. They have very strict relationship. And for example, between lung carcinoma and smoking, and also sometimes by other tumors, for example, by bladder cancers, and also by some cancers in the mouth, in the mucosa of the mouth, for example, squamous cell carcinoma of the mouth, or laryngeal carcinoma. Laryngeal carcinoma is very more common in patients which have the history of smoking. Animal fats when broiling and smoked meat can produce polycyclic hydrocarbons, and they are carcinogens, indirect carcinogens. Aromatic amines and azodyes, they are related to the bladder cancers. Aflatoxin B1 produced by a type of fungal element, aspergillus, that they found in stored grain and nuts. They are related to the hepatocellular carcinoma, the cancer of the liver. Some types of nitrate, which can be found in preservative of food, are related to some types of malignancy, especially to the GI tract and gastrointestinal tract malignancy. Mechanism of action of this chemical. Any gene may be the target of chemical carcinogens, but the commonly mutated oncogenes and tumor suppressors such as RAS and TP53. These two genes are very important and are very good target for chemical agents for carcinogenesis. This is not important. Some detail from the direct acting and indirect acting chemicals. Now about radiation carcinogen, ionizing radiation like UV, X-ray, radionuclides cause chromosome breakage and many types of genetic damage like translocation, sometimes point mutation, and finally they can cause genetic damage and carcinogenesis. The natural UV radiation derived from sun can cause skin cancers, and fair skinned people who live in some area who receive a great deal of sunlight are in more risk, greatest risk. Non-melanoma skin cancers, non-melanoma like squamous cell carcinoma and basal cell carcinoma are associated with total cumulative exposure to UV, but melanoma are associated with intense intermittent exposure like sunbathing. UV light has ability to damage DNA by forming some pyrimidine dimers, and this type of DNA damage is repaired, as we said before, is repaired by nucleotide excision repair pathway. Now a little about viral and microbial oncogenesis. One of the important viral factor which is related to the malignancy is HTLV1 or human T-cell lymphotropic virus. This virus has tropism to the T-cell lymphocytes, the type of CD4 positive type, and these cells are major target of this virus. And you know, this transmit only by sexual intercourse, blood products, and breastfeeding. And leukemia happen only in about 3% of infected person after a long latent period of time, about 20 to 50 years. Now about another virus. There are many types of this virus which is related to some types of neoplasia. For example, type 6 and 11 is important in the genital wart, and we call them low risk HPV. And some of the HPV are high risk, for example, type 16 and 18. And they are related to some types of uterine cervix malignancy, squamous cell carcinoma of the cervix, and also some malignancy of the tonsils are associated to the HPV. HPV oncogenic potential is related to two genes, E6 and E7. They are very important. E7 binds to RB gene, and E6 binds and degrades the P53. So by the damage to the RB genes and P53, the HPV can cause some malignancy. You said about EBV, Epstein-Barr virus, and you know that this is related to some types of lymphoma like Burkitt lymphoma. And you know about hepatitis B and hepatitis C. About 80% of hepatocellular carcinoma is related to the HPV and HCV infection. And the oncogenic effect of HPV and HCV is multifactorial, and the dominant effect seems to be immunologically mediated chronic inflammation. As I said before, in any situation of chronic inflammation, we have a compensatory proliferation of the other undamaged cells, and in this situation, we have some acquired mutations in this area. So in the site of chronic inflammation, we have hepatocyte death, and after that we have regeneration in the other cells for compensation of the activity of damaged cells, and finally we have genomic damage in this area. And about bacteria or H. pylori, you know that the first bacterium classified as a carcinogen was H. pylori. This is related to the adenocarcinoma and also to the lymphoma. And the mechanism is like the HPV and HCV, and because of the site of chronic inflammation. The sequence of histopathologic changes is at first chronic inflammation or chronic gastritis. After that, we have atrophy. The meaning of atrophy? Loss of anything or decrease in the size of glands. After that, we have intestinal metaplasia of the lining cells. It means that we have some goblet cells like intestinal tissue in the stomach, and after that we have dysplasia, and finally cancers. And you know that this sequence takes decades to complete and occurs in only 3% of infected patients. Also, as I said before, H. pylori is related to the lymphoma and also to the adenocarcinoma, and the type of lymphoma is mild lymphoma or mucosal associated lymphoma. Okay, now about effects of tumor on house. You have 1 minute time for study this slide, and then you can explain this.
المادة تثبت
Who's ready? Okay.
They're saying that the location of the tumor is important. So, for example, a small tumor, even if it's benign, if it's somewhere near something important, it can cause a lot of damage. damage. For example, a small tumor in the pituitary gland can compress the gland, the pituitary gland, and cause hypopituitarism. Even if the tumor is benign, it will still cause this effect. Or for example, a small tumor in the wall of the renal artery may compress it, which causing renal ischemia and hypertension. Even though it's benign, it still causes a lot of damage.
A lot of damage, yes. Thank you so much. Exactly, you know, for example, about leiomyoma. Leiomyoma is a type of benign tumor of the smooth muscle, okay? And sometimes we have a lot of leiomyoma in some patients in uterus, for example. And some of them are very large in the uterus. For example, about sometimes 20 centimeters, 10 centimeters, okay? But the patient have no sign and symptoms. Sometimes they show only a little abnormal bleeding, for example, a spotting, something like this. But a small myoma in an important artery, for example, in renal artery is very important and is very crucial for patient because this artery is very important for a renal blood supply, okay? So the site of tumor is very important, location is very important. Another important thing is cancer cachexia. You know about cachexia? Did you hear anything about cachexia? Did you see any cancerous patients? They are very thin. Yes, okay.
I think cachexia, it causes muscle wasting because
Yes.
of tumor necrosis factor.
Yes, exactly. Some patients have progressive loss of body fat and loss of body mass. You see that they are very thin, very weak. This is cancer cachexia. And this is because of some soluble factors like cytokine that produced by the tumor and also some of them produced by the host cells. Like TNF is very important. TNF is tumor necrosis factor produced by some macrophages in response to the tumor cells and can make this sign and symptoms. Now about paraneoplastic syndrome. As I said in the beginning of class, paraneoplastic syndromes are some systemic symptoms that we cannot explain them by the tumor site or by the, for example, metastasis of the tumor. They appear in about 10% of patients with cancer. For example, sometimes we have hypoglycemia and decrease in the blood glucose in some patients, and we can't explain that why, and we call them paraneoplastic syndrome. The most common paraneoplastic syndrome are hypercalcemia. In many patients, we have hypercalcemia, and sometimes we find the patient at first by hypercalcemia. We see that one patient in the test show hypercalcemia, and we don't have any cause for this. And after that, by some imaging and some other tests, we can find a primary tumor, for example. And also Cushing syndrome. You know Cushing syndrome, what's the Cushing syndrome? Exactly, this is because of ACTH, adrenocorticotropic hormone, as you said. They have very round moon face, yes, buffalo hump because of accumulation of fatty tissue in the posterior neck. They have fatty abdomen by thin limbs. Yes, this is Cushing syndrome, and some patients by cancer show Cushing syndrome. The neoplasms that most often associated with paraneoplastic syndrome are lung carcinoma, and also breast cancer, and also hematologic malignancy. These three types of malignancy show more paraneoplastic syndrome. In this table, you can see some example for this. For example, Cushing syndrome can be seen in a small cell carcinoma of lung, sometimes in pancreatic carcinoma, and some neural tumor. And they are because of the production of some ACTH-like proteins by the tumor, okay? All of them are produced because that tumor can make some material which they are look like to the other hormones, and they can act like that factors and that hormones. Now about grading and staging of the cancers. What's the meaning of grading and staging, and what's the difference between them?
They categorize the cancer based on, I think, how developed the cells or how differentiated they are.
Yes, this is grading, yes? Yes. We can grade the malignancy as low grade and high grade. And also sometimes we have 4 stage for grading, for example, grade 1, 2, 3, 4. And higher grade tumor have more pleomorphism, more cellular atypia, more mitotic figure. So the grading is based on the cytologic differentiation, and also by the number of mitotic figure in the cell. So for grading, the mitotic figure, pleomorphism, cytologic differentiation are very important. So the tumor by more pleomorphism and more mitosis is high grade, and the tumor with little mitotic figures and very few cytologic atypia with good differentiation are low grade tumors. So for grading, cytologic differentiation, mitosis, and anaplasia. What's the meaning of anaplasia?
Loss of differentiation.
Loss of differentiation, very bad shape and bizarre shapes of the tumoral cells. So, for example, the size of tumor is not important for grading, or metastasis is not important for grading. Okay. These are for staging. In staging, we have many types of staging system in our pathology report. We use, for example, from TNM staging, AGC staging. One of the most important staging system is TNM staging, okay? A staging system. Okay. This is the last slide. And for example, I said TNM. T is for tumor size. Okay. T is for tumor size. N is for what? Nodal metastasis, lymph node involvement, or nodal metastasis. And M is for metastasis. Yes, exactly. Metastasis. So in any pathology report, maybe you see, for example, we say that this tumor is T2, for example, N1 and M0, for example. It means that based on the size, it is in T2, and they show some metastasis to the lymph node structure, and we have no metastasis to the distant side. Okay, this is staging and grading. Okay, now for your lab, we have today 2 slides. Hamartoma and hamartoma, I think. Yes. Your previous class was hemangioma, yes, hemangioma. You learned about hemangioma in your previous teratoma and hemangioma. You learned about them. Okay. So today we have hamartoma and okay. About lipoma. What's lipoma?
The benign cancer of the lipid.
Yes,
benign
benign,
lymphocytes.
benign tumor of lymphocyte origin. Yes, they are very common soft tissue tumor. Most of them are subcutaneous, and most of them are small, less than 5 centimeters. And they are very same to the normal fat. Okay, by microscopy and also grossly by radiology, they are like a fat tissue. This is a lipoma grossly. On macroscopy examination, you can see a round tissue with a capsule, a thin capsule. You can see the capsule as a shiny tissue, which is surround this mass. And this is a yellow mass-like lesion. And here in very low power, you can see fatty tissue. You know that this empty-like area are fatty tissue because in the processing we use from ethanol, and by that the fat is removed and we can see them like empty space. And you can see here lymphocytes, the mature lymphocytes here, proliferation of the mature lymphocytes. And in the top of the slide, you can see a thin fibrous capsule, and also some fibrous septa, which made some lobules of the lymphocytes. And in the higher power, you can see these cells. These are the lymphocytes, mature lymphocytes. For example, all of them are like normal tissue, normal fat tissue. The nuclei are very small in the corner of these cells, and the entire is empty. And also you can see some septation, some septa, and some blood vessels between the tumoral cells. So this is lipoma. And now about hamartoma, I think. Okay. Hamartoma, what's hamartoma?
Abnormal tissue at normal origin. Abnormal tissue at normal origin.
Yes, what's the difference between hamartoma and choristoma?
Choristoma is normal tissue at abnormal.
Abnormal site, yes. For example, sometimes in the stomach mucosa, we can see a mass-like tissue from pancreatic tissue, okay? This is choristoma. But hamartoma, the cells are from that origin, but they are accumulate and proliferate in abnormal features. So benign neoplasia composed of varying amount of mesenchymal elements like cartilage, fat, connective tissue, and smooth muscle with entrapped respiratory epithelium. In hamartoma, at least 2 mesenchymal elements should be present, and this is most common benign pulmonary neoplasia. Composed predominantly of varying degree of mesenchymal tissue, hyaline cartilage, fat tissue, muscle, and bone. Other connective tissue elements may be present, like some gland spindle cell, fibrous tissue, and sometimes we have entrapment of epithelial cells, respiratory epithelial cells. This is low power of hamartoma. This structure, this irregular structure, are the epithelial, respiratory epithelial structure, which are entrapped inside the hamartoma. And this myxoid tissue and also some smooth muscle proliferation in this area, these are the hamartoma. And here again you can see the respiratory epithelium, the epithelium which is entrapped inside the hamartoma and is very irregular and in different shape from the normal respiratory epithelium. Again here. And here, what's this?
This is alveoli.
Cartilage. This is a type of hyaline cartilaginous tissue. Here we have cartilage. We said that we should have 2 types of mesenchymal tissue, for example, cartilaginous tissue. And what's this and this? For example, what is this?
Vessel.
Vessel, yeah.
No.
Oh,
It's not, this is vessel. This is vessel by a thin endothelium and many RBC inside that, or like this is vessels, but these and these have epithelium, have a respiratory columnar epithelium, so this is gland-like structure, as we said before, that they are entrapped inside the hamartoma. What's this? Cartilage again, yes. Finding cartilage is very important in diagnosis of hamartoma. So this is a cartilaginous tissue again in hamartoma, and finish. Okay, you can go to the lab for the slides. Any questions?
Thank you, doctor.
Thank you so much. Have a good day.